Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to today's podcast. We have a great show today brought to you by One Touch Telehealth and the nonprofit Humans Helping Humans. We're going to be talking about best practices in scaling a behavioral health organization. I have a great guest for you today. He brings 3 decades. He is Texas-born behavioral health executive, Gary Larcenaire, who's dedicated his professional life to addressing the challenges facing people with mental illness, their families, and their caregivers. He's the CEO of Valley Behavioral Health, a nonprofit network of clinics providing treatment for behavioral issues, addiction, psychiatric concerns, autism, and other chronic health conditions. He's working on expanding services the Valley provides to the community in Utah and the surrounding states. Gary, welcome to the show.
Thanks for having me. It's exciting.
Yeah, well, great. This show is really, you have an amazing journey. You've done amazing things in behavioral health. And I want to talk a little bit because we get questions all the time that nonprofits and for-profit behavioral health companies, whether they're in mental health, whether they're in addiction, really struggle to not only scale, but to turn a profit. You've done this not once, but twice. So tell me a little bit why you think that others really struggle from your experience with getting that profitability and getting that scale in behavioral health.
Wow. Medicaid is an interesting thing. It's got regional nuances, and I think that makes it's much more complicated to build Medicaid in certain areas. It's not standardized, and so it's an impediment in many different ways. Your IT systems have to be customized to do local type of billing, so they're not scalable multi-state, because when you go to another state or another region, the rules are different, the billing's different, the logic is different, the cascading is different. So it creates all these inherent complexities that are far in excess, I think, of what other healthcare providers that are predominantly billing commercial markets are experiencing. And so that sort of bogs down the whole system when you don't have that standardization like that. And so the big focus is that I've really learned to try to deal with that is to set up a revenue cycle system that can adapt to these types of changes, that can pivot, that can be agile. There's so many times that we've discovered we're leaving money on the table. Yeah. Because the revenue cycle team didn't have the information that they needed to complete the transactions and to ensure that we were billing successfully. So a huge part of making, I mean, you're trying to make a business model work on the thinnest of margins you can possibly imagine. I mean, I've read that the airline business runs on very thin margins, and if they could just eke out a couple percentage points, they're considered to be successful. And I think in behavioral health, it's even worse than that. So any inefficiency in the system results in just a terrible ripple effect through your financials. The other thing is your front end staff. When you have a clinic that's focused predominantly on the Medicaid population, they have all these sliding scales and these differences in the way we can treat them, and then many times the patients that come to see us on the Medicaid side of our business are experiencing really complicated behaviors, and so we end up defaulting into no pay. We call it self-pay, but we're not going to get paid.
Right.
And so it's very confusing to have a front desk person trained where everything has a potential exception.
Right.
Whereas in a commercial clinic, it's, I need your copay. Do you have your insurance card? It's all very straightforward. It's very transactional. It's the way it's supposed to be. They type in your insurance, it pulls up. There is no sort of indigent fund, and so it's a much cleaner business transaction than on the Medicaid side. So I think part of the problem with the business model is that a lot of providers see themselves exclusively as Medicaid providers. That is their identity. We are a Medicaid provider. We are an indigent. That is our focus. And then they'll say, well, yeah, we also accept insurance, but they really haven't developed the systems, the muscle memory, the business processes, the back office, the collection protocols, really to maximize any of the commercial paying. Additionally, rates from Medicaid are sort of just forced on us,
Right.
Unilaterally. There is no negotiation typically. Rules are unilaterally negotiated, whereas with our commercial partners, we go to our commercial partners and we work out rates and we work out different types of business arrangements that work for both of us. And so I think a key aspect of making sure that you're going to be relevant and alive as an organization in this industry over the next 20 years is you've got to figure out, you cannot rely on the Medicaid dollar as being your primary source of income. You have to diversify that. The other thing is, a lot of times the market demographics of the commercial market versus a clinic that you're serving people that maybe just got out of jail, they're on probation and parole, maybe they're being escorted by police officers into the clinic. It scares them. The average person trying to get just family therapy is going, whoa, this is a side of society I don't really want to see. It scares me, and I've got my kids here and everything. So what we've done is we've pulled the business into two segments, rebranded, different color schemes, different name, everything else, different clinic locations, and we accept no Medicaid in those clinics, and exclusively commercial. And they become almost like, I use the analogy of NASCAR. Why does Ford and Toyota, why do they engage in racing? And a lot of it is R&D. You're trying to figure out how to make your brake pads better and make your engines run at higher RPMs, and then we all benefit in the retail market from those things. Our commercial clinics are very much like that. They are constantly figuring out the billing algorithms, the best way to do things, the business transactions, and then that learning then is transitioned into the Medicaid side. So I think for us, the success has been to bifurcate the brands, make sure that you're serving your appropriate demographics in areas and in clinics where they're comfortable, that you're staying on brand. And then I think a big issue that I have seen in my industry with my colleagues over the years, and you almost get conditioned to it as well, is we tend to farm out the support services of our clinics, sometimes the most profitable lines of business that we have, to private providers. So somebody will brag, we've got an on-site pharmacy. Okay, who runs it? Well, there's a for-profit company that's paying you rent, and you're sending them a ton of customers. I mean, our pharmacy does $1 million a month.
Yeah,
$1 million a month, and
so
we were farming all that out.
Let's talk about that. So you went kind of against the odds, like you said, of industry. You brought in labs, pharmacy, wellness clinics,
Vertical integration.
Exactly. So obviously it's, a little bit risky, but it also, risk comes a reward, right? And to your point, you're referring this to somebody else. So how long did it take you because, when you came on, you didn't do that, right? And then you started looking, I'm sure, as a CEO at numbers and all this kind of stuff and said, hey, to diversify, why aren't we doing this, right? So how long did it take you to kind of go through that journey that said, hey, man, this makes sense for us to bring this in-house? And what were the types of things that you looked at that said, okay, that makes sense to keep outsourced. This makes sense to bring in-house. Give me a little bit about that mindset.
Well, I've been blessed with a great board. Our strategic planning retreats have generated great ideas. They're all from the business community. So their thinking is very their thinking is not your typical not-for-profit sort of mentality. The prevailing thought and wisdom that went into our strategic plan was business diversification, vertical integration where we could. I mean, incentivizing management to bring business plans to the board and have them vetted through a very, very sophisticated leadership and finance committee, and then saying, okay, if you hit these numbers, we're going to financially reward you for diversifying the business and for fulfilling our strategic plan. So if the board was unwilling to put money behind the risk, and say, look, just do it, and if you fail, bad on you, and if you're great, so what? The management team would just kind of stare at me blankly. I mean, like, why would we want to take on a pharmacy?
Throw our neck out there.
Throw our necks out there for all this risk to start a CLIA certified lab that's super complicated, heavy, $500,000 capital investment, hiring lab scientists. I mean, doing all these kind of nutty things because you're just outside of your element and you're taking on all this risk. And if your teams aren't getting rewarded appropriately for that risk, then it's just not going to work. And a lot of times in not-for-profits, I think we're afraid to pay for performance. And so we do, we get what we pay for, quite frankly. And what ends up happening is there's more reward, and this is kind of a controversial thought, but there's more reward. Huh?
I love controversy.
Well, you've got the right guy. There is more reward in avoiding the risk and going to these awesome conferences where you've got all of your stuff outsourced to all these vendors, and they take you to dinner, they take you golfing, they treat you like absolute royalty, and you get to do that 4 times a year, 5 times a year, whatever conferences you want to go to. That becomes your perk as an executive, and you send your teams and board members and all that. But when I got here, the first time I sat down to one of those steak dinners, I thought, wow, we must be really paying these people a lot of money. I mean, like, they must be making a ton of money off of us. And so that's when I started digging through their business models and going, whoa, we're outsourcing some of the highest margin stuff. We're keeping like
the low
margin stuff and farming out all the profitable stuff. And so that's when we looked around, and the entire team started going, okay, let's look through all of our contracts. Let's look at what we can do. What is within our
bought us the best dinners. Start right there.
Yeah.
So this is a PSA for all the pharmaceutical and medical device companies listening. Stop buying expensive dinners. Gary's going to have you right on the top.
Well, yeah, I'm going to be trying to figure out how to keep that money in my company.
Exactly.
And expanding services as opposed to just enjoying sort of the luxury of being at the highest levels of the company.
Yeah.
So there are consequences to that. I'm never going to be voted visionary leader of the year at some conference, because those things are all, if you go to a conference, the big draw is your vendor booths. I mean, that's where you go. That's where all the vendors are, and they support the whole conference. And so if you've got a reputation as being a guy
I say that all the time, you know, every industry, and, you know, I get slashed for it. It's like, you know, every industry report, you can pay to be at the top of any industry report you want to. It's not about who's like you said, most innovative. It's not about who's actually has the most innovative technology. It's who sponsored that report. Are they the platinum, the gold, or the silver sponsor? They're going to be the one in the chart that's going to be like the best. I always tell people, if you buy off that report, that's on you. That's on you.
I always said, you know, if you get a really big industry nomination award, you probably should at least be like the NASCAR drivers that wear the logos, like this is my EHR, or my electronic health record company, this is my lab and pharmacy,
my scheduling,
and these are the guys that put all this conference together, and they all think I'm awesome because I give them all my business. And so there are sort of social consequences to me professionally, that don't feel great, but my loyalty and my fiduciary responsibility is to Valley Behavioral Health and to this industry. And if I see a better way to make this company serve our communities with better outcomes and better partnerships, you know, that's what I do. And I
knew that's why we got along, because I'm the same thing. It's, you know, if you're not ruffling feathers, then you're not doing your job. The best companies out there are the ones that are doing innovative things, making high margins, making revenue, but aren't out there saying, hey, look at me, look at me, look at me.
Right.
Like, you know, you don't need that praise if you're doing the right thing, you know? Right. So back to what you said earlier, you were talking about the scientists. I do want to talk about, because being your controversy, you're a tech guy and you've invested a lot in technology, doing cool, innovative stuff. You got data scientists, which is pretty unheard of in behavioral health, for, you know, maybe for the health systems or the payer side, but not for the clinics and facilities themselves. Tell me what drives, you know, you from a technology standpoint of investing in technology, and rather than kind of following the pack, really leading the pack on the technology side.
You know, I just think behavioral health has been such a profoundly neglected sliver of healthcare that and the reason that I'm drawn to it is because my oldest brother suffers from refractory schizophrenia. So I remember growing up with him. He was a drummer, and I remember growing up with him and thinking, wow, there's really nothing they can do for him. You know what I mean? It was pathetic, actually, that you could be sick and go to the emergency room with pneumonia, be treated like, you know, with dignity and respect. Yeah. But whenever he had a psychotic episode, he was treated like a criminal.
Yeah.
And so I saw that from a very early age. And as I started to study in college, and then I went to work, and I went to work in this, you know, I mean, I wouldn't even have the furniture I wouldn't use any of the furniture. The first place I ever worked, I wouldn't use their furniture. That furniture would be burned in a dumpster somewhere. It looked like a third-rate, I mean, it was terrible. It smelled bad.
Yeah.
It was embarrassing. I wasn't proud to work there. I felt like I like almost like, wow, I've really ruined my career here. This is terrible.
I'm not gonna invite friends over.
And I mean, you know, I was paid absolutely nothing. I mean, it was ridiculous how little I was paid with a 4-year degree as a case manager, and just a struggle to try to get through that. And I I thought I was going to get a PhD and be a therapist and a psychologist and do testing because, I scored really high in those types of things, and my GPA was very high. So they offered me a full scholarship to do those things. But one of my professors, one of my mentors, he said, get out there and do some work, some field work, and figure that out first before you declare what you really commit. And those years that I spent as a case manager, I realized how incredibly backwards and inefficient the whole clinic design was. And so I aspired to try to make a difference, not just for 35 to 40 people on my caseload, but to make a difference in the industry and try to modernize it, because it was so embarrassingly backwards, and it doesn't have to be that way. And I still, to this day, go into clinics and I think to myself, wow, the analogy that I use is when I'm talking to new employees is, I remember some of the biggest technological advances when I was a kid was when my dad gave my mom the 20-foot cord so that she could walk around the house on the phone and whip it over the kids' heads, and we'd duck and she could talk all over the place, right? I mean, and your phones were hardwired into the wall, with wiring, and then we split up the bell, the big bells, the monopoly, and look at what we've got now. I mean, it's amazing. But what ends up happening is because Medicaid is so brutally difficult to bill and to deal with regulatorily, that you end up with these little monopolies. They're centers there that have no challenge. No one wants to try to take their market share from them. Yep. And so because of that, they're still delighted with the 30-foot cord. And I'm going, hey, we need to diversify and make this industry what it needs to be. It needs to be a respected aspect of healthcare, funded appropriately, and it needs to be treated in a competitive environment. So many times we protect these local monopolies from any external competition whatsoever, and all that does is it hinders innovation. And so what I'm banking on, I am banking our future on the fact that eventually we're going to wake up to this. I know for a fact, because we're doing so much work in the ACO and in the commercial markets now, that they are coming to us absolutely starved for a partner that speaks their language of, risk-based partnering, risk corridors, accountability within your system of care, access standards, measurable metrics that you hold people accountable to. They're so thrilled. I mean, we're being heralded when we go into markets as, oh my gosh, please come here and improve this environment that we currently have with your technology and your innovation. And so we are. We're literally being drawn into markets now, where, for instance, in Idaho, we're partnering with some developers there in a large health system, negotiating what we're going to do to build an entire campus, a fully integrated campus, and they have seen our technology, they have seen our branding. I mean, that's another thing that I think a lot of behavioral health organizations don't really pay much attention to.
Yeah, it's always branding. Websites, branding, everything is usually always an afterthought.
Right. So you're not on social media. You're not. Your brand is off. You walk in and your clinic manager brought in some art from their garage and hung it on the wall, and that's the way it's decorated. True. And every clinic is different. I mean, when you walk into a McDonald's, you're in a McDonald's. You don't think you're in a Taco Bell, and so they understand what branding is and the reinforcement of branding, and our employees have to, we do brand inspections with all of our clinics, our Medicaid clinics and our commercial clinics.
Love that.
To walk around with a checklist and say, you can't have a pink throw pillow. I know you like it, but it's not on brand. These are the branding guidelines. And so that type of consistency and accountability, somebody posted.
How you scale. But going back to the top of the thing is that's the only way to scale, to have those checks and balances, to have that technology, to have those brand standards, to have all that. Otherwise, you're going to have hodgepodge solo locations that every director is running their own show, and there's no accountability, there's no synergies,
there's no standardization of processes either. I mean, we are producing people from universities that are coming out, and we have our own. We've published a textbook that's this thick. We have to start their education over. I mean, great, you got the license, but come here, let's actually show you what it's really like to work, You
should listen to is a college degree required podcast we did a few weeks ago, where executives are saying, that's great that you got some core coursework, but now let's throw it out and roll up your sleeves and really learn what it's like.
Yes, exactly. And how to understand all aspects of the business. One of the things that somebody was trying to hurl an insult at me, an employee who was disgruntled, said, "You run this place like a business." And I was like,
thank you.
Well,
your comment on your exit interview.
He's like, I went into mental health because I wanted to do, mental health charity work. And I'm like, well, we are doing those things. We still finance free care. We do pro bono work. But we expect a level of professionalism and standardization to set an example, to set a standard, and to, I think part of the problem with the stigma of our entire industry is that we don't really have our act together either. Yeah. We don't like to partner. We don't really like to collaborate. Yeah. Everybody's got their own closed shop.
Very closed vested. I've learned that of being this, mental health influencer. I've really been trying to take down the walls, because you have a lot of companies that are doing amazing things, but everybody's so close to the vest that someone's going to steal the next big idea. And my thing is, if we're going to take down mental health stigma, if we're really going to affect this youth that has the highest suicide rate that we've ever seen, if we're going to start having these conversations, if we're going to keep talking about this rural shortage and not figure out, now that telehealth and telemental's there, that you can reach these people and that you can bill for these things, and that you can have, different types of hotlines, and not everybody needs inpatient treatment. I think there's a lot of stigmas, not only with the population, but in the industry. And I know you have strong opinions on this, but not everybody's at rock bottom to get fired from their job, as you said, come out of jail, be so addicted that everybody's turned them out, that they have to do inpatient treatment. And we live in this world where everything's instantaneous, that, there's obviously a ton of studies that say outpatient treatment can be just as effective as inpatient treatment, or more effective, depending on who you believe.
Yeah, I agree wholeheartedly. I think one of the things is that has not helped us as an industry has been how we're defined as successful. So let's say you're a teacher and you've got a kid who has experienced home trauma. They're enduring it on a daily basis. They're disrupting your classroom. They're getting into fights. And then, so you call the psychologist, and the psychologist then calls us, and then we put them in a special classroom, isolated away from everyone else, with all the other kids that are experiencing difficulties, and we're considered successful. That's it. Why? Because the problem's gone, right? I mean, yeah. the guy on the corner who's mumbling to himself, if you come and do an emergency detention, you're successful. You good on you, right? But when it comes to like that dude that was on the corner, like what did we do for them except just extract them? There was a guy on my caseload, his name's Kenny. I loved him. He's a Vietnam vet, covered in tattoos. Kenny was never in crisis. Yeah. He made everybody else crazy around him, because he was scary looking, and he would ask you for money and panhandle and stuff like that. And so they'd call the cops on him all the time, and I'd put him in my truck and go, Kenny, you got to stop doing that. And he's like, man, I just want a cigarette. I mean,
Yeah.
and so what did we do for Kenny? Well, I know what we did for the manager of the 7-Eleven by removing Kenny from the 7-Eleven. And so, yes, we're heralded as heroes, but did we help Kenny?
Right.
And the issue that I'm not really seeing is an obsession with outcomes. We're just, if to me, so I break our system up into phases of care. So to me, phase 1 is like, maybe an easy understandable example would be you have diabetes, but you don't really know it. And then you just collapse one day and you find yourself in an emergency room. That's phase 2.
Yep.
And then phase 3, or 2.5 to 3, is teaching you about your condition,
Yep.
educating you about how to manage your diet and your exercise and your sleep routine,
yep.
the disease management. It's a chronic disease management. And then making sure that phase 3 is a well-crafted plan for you not to enter phase 2 again. So phase 2 to me is any place you do not want a loved one to call you from.
Yep.
Inpatient psych, an emergency room, under a bridge, a homeless shelter, all of those things are jail. All those things are, to me, phase 2. There's the least quality of life for the human being in phase 2 care. It's the most restrictive environment, and it's the most expensive for our communities. So what I find over and over again is that we fail to plan for phase 3 very well. A lot of times the treatment plans are just this, we change the date.
Yeah.
Their treatment clearly failed. They were in the hospital, they were in an emergency room, they were suicidal, homicidal, something happened. We need to look at their meds. We need to look at the social circumstances that they're in and refine it so that we can prevent a phase 2 relapse. And so when it comes to vertical integration, phase 2 is not something that I will permit in my system, because what I tell my employees is, if I have a hospital in my portfolio, what am I going to want to do?
Readmission.
I got to fill it, right?
You want them coming back? Yeah.
I got to fill it. Well,
if I get readmission rate's so high, because
if I get rid of that,
yeah,
then it's, and so what we do is, if a lot of times these providers, what I've noticed is, if we were playing a football game, they stand in the end zone, the client runs for a touchdown, scores, and then they shove them out.
Yeah.
And it's like, what this is all reactive care. You're not doing anything proactively to make sure that this person ends this cycle of suffering and or mitigates it to the very best of our technological and social abilities. And until we see that, as an industry, I just think it's unfortunate, because it needs to improve. It's an unmet need. It's an increasingly unmet need, and I think it's because we are more complicated as a society. Just living and navigating within this world is more complicated than when I was a kid.
Yeah.
I mean, we played in the dirt. We had rope.
You drank from a water hose.
We drank from the water hose. We played on bikes. We didn't wear helmets. I mean, the world is much more. I mean, you've got social media and all these stressors that are different now, and so our industry has to grow up. It has to mature, and the thing is that I will share everything we've got, because I don't worry about anybody coming in and stealing our market share, because quite frankly, if they can, they should.
Yeah, good for them, right?
It'll be a reminder to my employees that we need to catch up.
Right.
We need to,
get going.
Constantly innovate and not become stale.
Yeah, no, that makes a lot of sense. So one quick question before we go, as we look at demographics like Gen Zs that are the youth that are having, highest suicide, that are a video first calling demographic. If we look at rural areas where there's one psych for, a million people. If we look at, which I don't even think we've even seen the full effects of the mental health that we're seeing in the boomer generation, where there's a huge stigma, right? As we look at all those kind of moving parts, you're a tech guy, as we have, telebehavioral, telemental, whatever you want to call it, how do folks use that to reach some of these demographics for the aftercare plan, for crisis, for routine counseling? Where do you see that technology plugging in the best on the behavioral health side?
Well, I, up until, discovering your product, hated we literally just wrestled with the technology. We were looking at, we were like, okay, we're just like throw up our hands and we were going to open up a clinic in a rural area that was 3 computer screens, and a social worker / receptionist, great job, and also somebody who was good with technology, because everything was glitchy. Nothing was working for us. And so it was great. And at all the conferences, they talked about the innovation and everything, but the technology really wasn't all that great. I mean, it can't be, it has to be seamless. It has to be easy to use. And the code, I'm sure, is super complicated behind the scenes, but the user interface, it has to be smooth, or else it becomes the topic between the therapist and the client.
Support, your tech support.
Yeah, and so they're frustrated. It's they've got the cameras pointing up at their ceiling, and they're, can you see me now? And it becomes all about that and fighting the technology. What you guys have done is make it to where we can use it, because what we need, for instance, in autism, we have a significant issue with autism in Utah. And our rural areas lack trained therapists that because they simply can't make a living in these rural communities. So you've got these children with autism and no specialists available. But you don't need to take the kid to a clinic to log on. What you need is the mother to have, or father, caregiver, to have the ability to click a button and show the behavior to the therapist that this is what they're doing. They're beating their head against the wall. What do I do now? Like, take me through the steps therapeutically of how to intervene. But it has to happen then.
Now. Yeah.
Right. And so, up until we discovered your product, I mean, we just couldn't do that. Now, the sky's the limit. We'll be able to serve rural Idaho as well as urban Idaho, rural communities to the same extent. Our planners and our doctors and our therapists and all that, as they go through their schedule, there may be somebody in the lobby, and their next 5 appointments may be virtual.
And you could schools, serve more, from that without, schools have always been the double-edged sword, right? Because mom or dad has to take off work. You got the kids coming out of school. So I think we'll see more and more of serving it right in school from, a nurse's office or whatever. The reason nobody's been able to scale schools is because they had to buy expensive equipment. It can only be in one room, and so that's always been one of our missions is, how do you reach youth? Well, you use tools we're already using today, and you just make it really awesome and really easy to use, right?
Right.
So if you go tell a school, hey, you got to go buy 1,000 computers, and you need 1,000 of these specific this, and we got to change the room, then they're going to go, whoa, we don't have budget. We can't do it. If you go to a school and say, hey, we can do it with what you have today, it's a different conversation to serve that community. Mm-hmm. And some of these communities, I was at a school mental health conference that I spoke at earlier this week or last week. And some of these schools, have one counselor to 550 to 1,000 kids. Well,
and they're a lot of times they're trained guidance counselors. They're not
exactly. And then they escalate to like a mental health professional, right? But
right, you think
the point is, you don't know if a kid is suicidal, or you don't know when you've interacted with them once every 2 years, right?
Right.
You barely know a kid's name. You got a docket. And,
Right.
Everybody will say it's school funding and I shouldn't be talking about it, whatever, but it is what it is. So.
Yeah, it is. And a lot of times, the work that I did with children, I found that there were really bad parenting habits.
Yeah.
That were reinforcing bad behaviors because they hadn't, because that's probably the way they were parented, and so it's bringing out the worst, and yeah, and so I think by having handheld technology, I mean, I went downtown Salt Lake. There's 4 homeless guys sitting on a park bench, flipping through their smartphones. So, I mean, everybody has a smartphone, right? So if we can get more agile in terms of one of the things that we're talking about now is like flexible scheduling. Like, don't be so rigid in your scheduling. If there's a need, be available. If there's a spot to intervene and teach a parent something, be available. Don't say, well, I have a 2 o'clock. Just make the time.
Right.
To try to intercept the problem, so that you are de-escalating, that you're doing crisis interception instead of crisis intervention.
Yeah, that makes sense.
And so the technology, I mean, I think it's just a total game changer. My hope is that the payers will keep up with it.
Yeah.
They tend to lag behind the technology a little bit in the way they accept it. We have BrainsWay technology here it's neurostimulation that we've seen is super helpful in drug-resistant depression, but none of the payers will pay for it. So you have an empty chair, you have this treatment intervention that's wonderful and state-of-the-art, but the payers just don't accept it yet because they,
not enough data.
They say they do, but you have to go through so many. I mean, did you try beetle root from Africa? No. Oh, try that, and then we'll see if we'll pay for this. And so we've actually done some pro bono work on that, and seen miraculous changes in people's level of depression. But so we have to make sure that the payer systems are calibrated to this technology. Yeah. And that we're being paid to do it and encouraged to do it. Yeah. One of the payers said, well, I don't want to pay you for telemed if the person's at a homeless shelter and your clinic's only 4 miles away. Why not? I mean, do you want them to take mass transit, or you want them to walk 4 miles from the homeless shelter? I mean, why can't we just interact with them and get paid? Right. Well, it doesn't seem right. I mean, because they're so close that you could really do it face to face, and it's just like, really? I mean,
say, hey, when's the last time you walked 4 miles?
Yeah. Right.
With all kinds of luggage, right?
Well, and you've got if you've got your own car, sure.
You don't think about this thing.
Doctor, but their lives are a little more complicated than that. And so I think we have to really make sure that we're having the discussion with our ACOs and with our payers that they will adopt technology and encourage our exploration with these things.
Yeah, it's always a struggle. We've seen huge, waves over the last 12 months. And I mean, 2020 is really going to be the bigger year, but it's always lacking, but it's come a long way, especially on the Medicare.
Oh, no, I agree.
It's been pretty good, but Medicare. So, but Gary, it was so great to have you. We had such a great, amazing discussion today. If anybody has any questions, feel free to submit those and we'll get the answers from Gary. And make sure you follow, it's valleycares.com. Make sure you follow them in the amazing journey that Gary's leading an amazing team over there. And if
find me on LinkedIn. And we can exchange ideas, and that would be great too. If you want to connect with me there, I'm active on LinkedIn.
Yes. Well, thanks, Gary, again for being on the show. It has been a pleasure, and we look forward to following you guys' journey. You're doing amazing things, and I know the best is even yet to come from you guys.
Thank you so much.
Thanks.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.